Good afternoon, Margaret and Tom.
Hi, Jeff. How are you?
I'm well, thank you.
Good, good. I hear that it's kind of nice outside today. I haven't actually been able to step out the door and verify that. It looks nice out the window.
I just came in about 15 minutes ago.
Nice, good. Yeah, got to get a little of that vitamin D. We all need it by this time of year.
What is that over there? Okay. Rose is playing with my screen.
I'm playing with my screen.
It's coming through.
You're not losing your mind.
Okay, so who all have we got here?
So I am looking at our list of attendees, and in terms of work group members, it looks like we have yourself, Tom, and Sean all present. I did receive advance notice from both Kimberly and JJ that they are unfortunately able to make today's meeting. So with that said, I think we have everyone accounted for.
Okay. Well, then let us begin because it is 1:31. So officially, I will call to order the March 21st Innovation Work Group meeting. We have approval of the synopsis, as always, as our first agenda item. Tom and Sean, did you have a chance to look at it?
Yeah, move to approve.
Okay.
Second.
And if I third it, it's approved.
Unanimous.
Because it's all just the three of us. So that's great. We can move on. And so our first item up is a legislative update from Glenn Bailey.
And yes, a further update. So Glenn as well had some competing demands hit his calendar today. So I think Ali and I are going to tag team a little bit and do our best to provide probably not as comprehensive of an update as Glenn would have had, but to just share a little bit in terms of the latest on what's going on. So Ali, did you want to take it away?
Yeah, thanks, Margaret. Yeah, there was a deadline last week that if Bill didn't get a hearing scheduled, then it was essentially dead. So a bunch of bills got moved to hearings this week, which is kind of why Glenn is buried with fiscal impact and bill analysis requests, especially for tomorrow's hearings. And we just wanted to update you on a couple, and we'll send out a more thorough report by email or follow up at the next OHEB board meeting in a couple weeks. But I wanted to give a brief update on the Ways and Means hearing this morning. I know Jeff has tagged him with me on that before, and I'm sure you missed that, Jeff, but we delivered a really good presentation this morning to the Ways and Means Committee. Robert and Siobhan Martin from PEB, Robert Young and Siobhan Martin, and it's really well received. We didn't get anywhere near the number of questions that we have in the past, which is always a good sign. They were interested in the 3.4% performance and seemed to be good with everything. We really highlighted our many joint endeavors, initiatives between the boards, and which they always appreciate and like to see, and how we can best, leverage our purchasing power and leverage our size. We talked a lot about our health equity work, especially with the joint committee and the broader OHA goal, and yeah, that it went about as well. I got to stay and do a second one this time for the Health Policy and Analytics Division, and That also went well. There's quite a few more questions that were asked in PEV but that was probably expected. And anyway, the director said that it went really well after the meetings. That's always good to have a third party opinion, especially when they're your boss. But I did want to give you a brief update on some of the ins and outs, the hirings at the health authority. We have a new interim director, Dave Baden, who is was the CFO, is the CFO, and he'll assume that interim role until they can recruit for a permanent director. And good news is they'll be recruiting for a permanent HPA director as well. So that might mean I'm off the hook here at least hopefully by summertime, but we'll see. There's Dana Hargianani, who I think many of us are familiar with. She is moving on. So they'll be recruiting for that chief medical officer position as well, Tom, in case you're interested in that. Other than that, things are going well. The Ways and Means hearings are going well, and legislative session is going well. So, Margaret, I think you're going to give an update on a bill or two.
Yeah, just a little bit. Thanks, Ollie, by way of further updates. One thing I did want to mention, it noted from Glenn, is that so sort of as we think about the calendar, the next 2 weeks, there will be a lot going on. As April 7th is the cutoff for there to be a work session held and to have bills voted out of the various policy committees. So we'll be tracking all of that pretty closely over the next couple of weeks and expecting a lot of activity as things move through the process. This week we do have there's a public hearing scheduled tomorrow for House Bill 2878, which is the global budget pilot bill, which specifically makes mention of PEB and OEB as participants in that regional global budget pilot. There's a hearing scheduled for tomorrow, 3 o'clock tomorrow afternoon, and then followed by a work schedule session currently scheduled for next Wednesday, the 29th at 3 in the afternoon. So we are, I think we've gotten pretty close to final on analysis of all that information and are still working on some aspects of the fiscal impact, but tracking that one closely through the process.
And I should have mentioned, Margaret, that Sean Parkman had the pleasure of delivering those Ways and Means presentations too, and always did a great job at that. So I'm sure he didn't miss that today, but thank you.
So are there any questions? That's kind of in summary, the latest and greatest on the legislative front. Great. Hearing none, we can proceed. Jeff, one thing that I did want to call out, I noticed on the agenda is that I unfortunately inadvertently took off a break period. So if you look at the agenda for today's meeting, we are scheduled to meet for approximately 2 hours, and the break is not appearing on that agenda. So I would invite at any point workgroup members, if it seems appropriate to take a few minute break, to please maybe put that in the chat or raise your hand. Or likewise, Jeff, if you identify a place where you'd like to pause, to please incorporate that into the meeting. And my apologies that fell off the agenda.
No problem. Thank you. It's up to Emery to keep us wide awake and on the edge of our seats for the next, so we'll be able to carry through to the end.
I'll try my best. I'll try my best. I'm not sure this first one's going to be that interesting, but we shall do our best on this. Well, thank you, Chair. Sorry. Well, actually, moving on. So this presentation is actually a follow-up of what we presented a couple of months ago. So following that meeting where we initially presented the level of payment, there were some questions, and so we do address those in section 2 here on the agenda. I want to highlight a couple of additional slides and maybe some changes, but we're not going to go through this in detail at all. We're just going to kind of go over some of the highlights, and so you can peruse it at your own leisure. And if you have any other follow-up questions beyond the items that we go over, please feel free to, I guess, ask or email, and we will try our best to answer those. But moving on, let's actually skip this background slide and go to section 2. Thanks. One more slide. So this slide here kind of shows a lot of the questions we asked that were asked of us, and we did also go to the plans to kind of get additional clarifying answers to some of the responses. And this slide kind of talks about it. First, for Kaiser, some of the questions that we asked had to do with the exempt facilities. That inpatient and outpatient are higher than 300% for the 2021 data. And what Kaiser noted was, depending on the location of facilities, that could impact the reimbursement levels. Kaiser, as you know, is mostly in the Metro or I-5 corridor. So those are essentially capped by the 1067. So the non-Metro locations for Kaiser, as they noted, more difficult to negotiate the contracts and resulted in higher reimbursements. One area where there was a little bit of discrepancy between PEB and OEB for inpatient exempt locations was PEB was higher, and that was due to some catastrophic claims. So it was just kind of impacted reimbursement levels, a percentage of Medicare, as well as based on the location due to those claims. One other area where we asked Kaiser was talking about the professional facilities, where their reimbursement levels as a percentage of Medicare were higher than Providence and MODA. Their comment back there, you can see in the bullet, they use market benchmarks to kind of set their fee schedule. And that market benchmarks, they note, has some differences between what MODA and Providence may use for their fee schedules. It's just data sources, different targets. So their allowed costs are set so their fee-based revenue aligns with their cost to deliver care. And that's also further adjusted based on this market benchmark. And so in that case, the way the fee schedules were set were a little bit different than what we might be seeing from Providence and MODA. So those are the comments back from Kaiser. Actually, Tom, you had a question. Exempt. If I recall correctly, it was about 10 to 15% of the claims that fell into the exempt category for inpatient and outpatient for Kaiser. Yeah. Any other questions about Kaiser before we move on to MODA and Providence? Okay. For MODA, one question was about the behavioral health rates, and what they wanted to note was this was 2021 information, and since that time, the rates have changed quite a bit. There's a couple of reasons. One was they did increase due to market-based adjustments to comply, as well as to comply with the mental health parity legislation, which I can't remember the exact bill, but I think it required payments to be on par with that of medical physicians. So that increased the rates. Also, there were additional increases in response to market forces in 2023 based on the Oregon healthcare. Or sorry, I just noticed something, but so at home. So, but sorry about that. But based on the Oregon OHP fee-for-service behavioral health rates. There was legislation to increase the behavioral health rates across the board for various services for Medicaid fee-for-service, and that did, in response, create like market forces to essentially have higher rates for commercial services in this case. So that was impactful, but they've noted that they have recruited, had better recruitment and more positive relationships with behavioral health providers as a result of their increases. For Providence, their services for ambulance was a bit higher. It was due to a mix of ground and air services, and that ground services was about 335% Medicare, but air ambulance reimbursements are higher, and so that may have played a role in their reimbursement levels. One other thing we talked about with Providence is when we were talking and looking into some issues or questions regarding the level of payment, especially in comparison to what was done before. I think the analysis wasn't done exactly on the same basis between what we provided back in for the 2019 data compared to what we got for 2021. For 22, I think this is going to be kind of key. What we're going to try to do, Mercer, is to talk with Providence and the other plans to try to be a little bit more, I don't know if strict's the right word, but to be more consistent in our categorization of services. So, we want to be able to get the most value out of this report as possible. And so I think we'll talk with the plans about the labeling and where services are categorized and placed. So when we do compare across plans and types of services, it will be much more consistent. And Margaret, I believe the next report based on 22 data is due in September. So we'll want to do this over the next few months in order to be able to have the plans report data consistently for that report.
Yeah, that sounds good. It is a fall deliverable, so let's definitely put that on the work plan.
All right. Before I move on, are there any questions about the follow-ups? Okay. All right. So just quickly moving through some of the next slides. So we can just keep scrolling through this section. There are a couple of minor changes for Providence where we did clarify with them some of the changes. Let's just keep going, please, Rose. So if you compare versus the last presentation, you might see a couple changes, but I'm not going to go through those in detail. So if we keep moving on actually to the next section. More slides. Couple more. Keep going. Okay, additional comparisons. Let's move to the next slide, please. Thank you. So, Jeff, one of your, we can actually move to the next slide. Let's just hold there for a sec. Thank you. So, Jeff, one of your requests was to put this slide on a consistent basis between all of the plans. So the first slide in this section was Kaiser. And so it shows the same categories and where services weren't provided, in this case for MODA, it was maternity, broken out. That is left blank. But otherwise, if you take a look at this slide versus Kaiser's versus Providence's slide, all of the categories are consistent on the left, and so you can do a quick comparison in this case. And this slide does show Pavinois. Okay. The other new slides that we have, and if we move, I think it's 3 slides now. One more. Thank you. So I don't think we had this before. It was kind of like an OEB specific look and a PEB specific look. So in this case, you can see OEB. So Kaiser's in blue and MODA's in pink. And so you can see compare by the same categories as shown on the prior slide, the reimbursement levels between the two plans. So again, if something wasn't supplied, so in cases for instance, down below ambulance, Kaiser supplied it, MODA did not. So that's kind of different. All other providers. So was the opposite. So you can take a look and do a comparison on the different types of service, in this case, between OEB and PEB. And then on the next slide, we do have PEB. So we have the 3 plans in this case. So Kaiser, Moda, and Providence. So if you want to do a quick comparison across the PEP plans by the different carriers, you can take a look at it here. All this stuff is just re-summarized from the prior slides. So it's not really new information, but it's just a different look at it in case you're interested. Okay. So that's actually the presentation. As mentioned earlier, I think, we're going to have a new data coming up, and we'll want to be a little bit more, just be a little bit more diligent and be more consistent across the plans. We were trying to initially, let the plans run this analysis do it as expeditiously and easily for the plans as possible. But I think, if we want to get more value out of this, being a little bit more diligent about the taxonomy will help for future years, and that way we can also do year-over-year comparisons a little bit more. I guess you can take a look at it and trust that comparison a little bit more. Jeff, you have a question?
So did the carriers have a chance to look at these slides prior to Rose sending them out?
No, although I think, like I said, this information was pretty much all sent before, or was in the prior presentation. Is this reordering of it? So I mean, so no, to answer your question, but I don't really think any of it's really new per se.
Have you received any feedback or explanations?
We have not. I think part of the questions that we asked, initially on the follow-ups were to try to highlight where certain plans might have been a little bit different than the others. And so hopefully a lot of the areas where it might stand out a little bit, for example, here on PEB, the outpatient hospitals exempt from the Senate Bill 1067. You can see how Kaiser, as the top line, is at 388, while the other two are about 250. That was one of the questions we did ask as a follow-up.
And this is Tom. The kind of the relevance of that has to do with the question I put in the chat around what is the percentage of cost in those areas that are in the exempt. I mean, if it's 2% and it's 300% above Medicare, that's different than if it's 20% that's in the exempt category, or its implication.
Yes, and I think of the inpatient and outpatient claims, if I remember correctly, yeah, it's about 10 to 15% is in exempt.
And is that for all of them?
Or no,
All
this is
plans?
just for Kaiser in particular.
Okay. What is it? What is it for Moda and Providence?
I will have to get back to you on that
Okay.
one. That was, the Kaiser one was a question before, so that's why I had it off the top of my head.
Okay.
I'll have to check
Yeah.
on Providence.
Good.
And,
I mean, but, that's the percentage is important, and then what the actual percentage of the total spend in that category would be the other part that is necessary to understand its implication.
Yep. Okay.
Thank you.
Any other questions? Okay. Well, with that, I'll turn it over to you, Margaret.
Great, thanks, Emery. And Rose, we can go ahead to the next presentation, the next agenda item. So this next agenda item is just a brief update on the status of our performance guarantee planning for the 2024 OEB 2324 and PEB 2024 plan year contracts. We talked in a bit more detail last month at the meeting about these the two guarantees we have to work through the innovation work group. And the work group shared some thoughts, some input related to the proposals drafted. And so I wanted to just share where we are in the process in terms of working through the next steps on that. So with regard to the trend rate guarantee, And again, this is the guarantee that puts 5% of OEB and PEB administrative fees at risk for carriers, medical carriers, staying within the 3.4% cap on cost growth. So currently we are, after discussions we had in previous, in the meeting last month, we are working to draft some revised contract language to propose for Kaiser that would tie the guarantee to the annual premium rate increase for the Kaiser fully insured plans. We have some proposed language under review that we've drafted, and will be next step moving forward to share that with the carrier for comment and further discussion. Along with that, we are also drafting some minor revisions to the current guarantee in place in the MOTA and Providence contracts in order to add the administrative fees into the base year and measurement year under that guarantee. And the rationale behind that is if we're going to be doing the fully insured guarantee on a premium rate basis, it's just a little bit more of a better apples to apples, or more sort of equitable and fair comparison to also include the administrative fees in addition to the claims costs in the guarantee for MOTA and Providence. So that those revisions to the current language are also in process under review and will be shared with the carriers very soon here. And then we will be seeking their further comments on that information as we move into April and move through the process. That said, just to note, along with this revised language, we are retaining the fees at risk at the current levels in contract, which is the 2.5% of those admin fees at risk for staying greater than 3.4% or less than or equal to 4% on the premium or cost growth, and then the full 5% of fees at risk if annual premium or cost growth is greater than 4%. So that is the status on that guarantee. Happy to take any questions if there are any. If not, we'll be having further discussion next month.
Good, thank you, Margaret.
Great.
Do we have any questions? No hands raised? Okay.
Yeah, I'm not seeing any, and I'm kind of monitoring the chat and not seeing anything there as well. So we'll move ahead. The next update is related to the second performance guarantee that we discussed at last month's meeting, and that was the value-based payment guarantee, which would be the new guarantee we're proposing to add to contracts. That guarantee, again, was proposed at 5% of administrative fees at risk for carriers achieving value-based payment target levels established in the VBP Compact for 2024. In the discussion last month, there was some talk related to some of the challenges in advancement of VBP, particularly in the hospital setting, and sort of related in consideration of the current status of that. We are working on developing a revised language that would restructure the proposed guarantee a bit to take into consideration the current status of hospital VBP adoption. And then also along with that, consider approaches to potentially tier some of the fees at risk across the land categories. Particularly in the compact, there are separate targets noted for land 3A, which is provider upside risk, as well as land 3B, which includes both provider downside risk on the 3B level. So thinking about some opportunities to potentially tier the fees at risk across those land categories. So again, updated language is in progress there, and will be our next steps are to we're planning to move that forward and propose some revised language to carriers for review and comment. And I see, Tom, that you have your hand up. So please go ahead with your question.
Yeah, I mean, I understand how MOTA and Providence would be included in this one. I don't know how KP would be, as it is, integrated system with global cap and all of that. I think it's 4C. So do they are they even included in this a value-based payment guarantee or not?
Yeah, they would be. And the way, and I should be clear, the way that we would really try to structure the language would be to align with how the categories are described in the compact. And the language in the compact specifically says, 3A or higher and 3B or higher. So,
Yeah, I'm familiar with
um,
that.
yeah, so under that sort of language, I mean, the guarantee would still apply to Kaiser. They would be
Okay.
sort of in the or higher um,
Well, yeah, it
category.
just is kind.
Yeah,
It's kind of silly to. I mean, that's obviously they're not much at risk on this one, is what I'm trying to
yeah,
say.
sure.
And
Yeah, and
I'm
that's
just kind
a
of
valid. Yeah, that's a valid observation. And I think we've had some discussion around that, and I think when it comes, generally speaking on performance guarantees, I think the approach we have really been pursuing is to align as much as possible across PEB and OEB and across carriers.
Okay.
Sometimes it does make sense to differentiate a guarantee for a different contractor. But I think overall, when you look at sort of our collection of performance guarantees, some are probably easier for some carriers, and then other ones are harder for them. So I think it's a little bit of a definitely. I mean, definitely valid observation, Tom. I mean, we've definitely acknowledged that. But again,
Okay.
I think
That's fine. I mean, I understand the
Mhm.
idea of being consistent across carriers, but and consistent across OEB and PEB. It's just such a fundamental difference in terms of the
Yeah.
model that it's kind of meaningless. I assume it's meaningless for KP to try to get to 70% of 3B by 2024. In that's how the organization is structured. But and I know they have some things that are outside. It's not 100%. I know that they have some things that are outside, but it's has to be less than a 30% outside of that of the global cap structure of an integrated delivery system.
Yeah, and not wanting to answer for them, I will agree with you. I think that some guarantees probably present more of a stretch for some contractors than others. So
Okay.
I think I think hopefully when we look at the sort of package of performance guarantees we incorporate into our contracts, we are including things where there's everyone has some guarantees included where they have opportunity to stretch and improve.
Got
It
it.
just may not be the same guarantees for
Got
all
it. Okay.
contractors.
Thank you.
Yeah, absolutely. Thanks for the question. So I think Rose, you can go to the next slide. So just next steps, as I mentioned, the revised language is in process and will be provided to carriers for review and comment. We'll have another status update at next month's meeting. And again, our timeline is to finalize guarantees by late spring, so that by the time we're wrapping up renewals, we have agreed upon guarantees for next year's contracts.
Good.
All right, and if there are no further questions, we can move ahead to Centers of Excellence.
Okay, thank you.
Thank you. So this next presentation might take an hour. We'll see. So if we want to break in the middle of it, please let us know. But there are definite sections that we might result in a natural break in this case. But we wanted to have, I guess, pretty much entire Mercer team help present the Centers of Excellence development update, because there are various aspects of the COE that we are working on, and each of us are like pretty heavily invested in our, in various sections, and wanted to bring those updates and what we're planning on for the next few months in developing this COE for OEB and PEB. But moving on to the next slide. Our agenda shows here. The first is we want to talk about stakeholder engagement. I think, as we have a reset, we have some time to potentially talk to all the stakeholders and to try to get everyone on board and hear all the feedback. And James Matheson is going to help talk about the plan for that. Also, we have a call for action of the IWG board on guiding principles. So in order, we want to help lay down the principles and the intent behind the COE that will help with a lot of the project plan design as well as the stakeholder engagement, because the IWG can have a true statement on why we're doing this and what we're trying to achieve with it, and get everyone hopefully on board with that vision, that mission, and to improve the care for all the OEB and PEB members in this case. And then section number 3 will talk about where we are in the project plan, as well as some of the program design updates, as well as which includes things like the contracting requirements, some plan design potential options to talk about, as well as the updates on data and things like that. But moving on to the next slide, actually, one more, please. Stakeholder engagement. So as mentioned, we are getting data for the COE quality metrics from APAC. That process is underway, and we'll talk about it a little bit more in section 3. But while we're doing this, we reassessed where we are and what steps are needed to really help drive the COE forward. In terms of the concerns of the IWG, other members, facilities plans, everyone who's potentially impacted by a COE. So we are trying to align, hopefully, and we understand alignment may not be possible, because we are talking about very disparate groups with maybe different intentions or feelings about how healthcare is delivered. But we are trying to align as much as possible, especially around the COE. And we're going to do that through engagement, a more direct stakeholder engagement than beyond just the methodology document. So we're going to take those steps and try to actually talk about it and get the stakeholders involved. And the other thing, with a call to action, we would like to have the IWG adopt guiding principles for the COE. And so that section is actually section 2, and we'll talk about it in just a little bit. But Tom, you had a question.
It would be very helpful for us to have a list of who we view as stakeholders. So, obviously it's the carriers. It's the carriers, then identifying the facilities where these surgeries go. So far, I don't think there's been outreach to, we're talking orthopedic surgery right now. I don't think we've talked to the Oregon unit of the Orthopedic Academy, and apologize for my lack of information, but I don't know if it's an academy or a college or what it is. But the whatever the professional society for Oregon orthopedic surgeons, they are another, I think, key stakeholder for at least for them to understand what this is all about. And I would outreach once we finalized our guiding principles, and the conversation would probably mean making sure they understand what we're about and what our guiding principles are.
Yeah, definitely. I think to your point, Tom, the list of stakeholders, I think actually, if we move on to the next slide, and James, I'm assuming you're on to help discuss this, but actually, I guess this next slide doesn't really describe what you're looking for, but the following slide really does. But James?
Yeah, Tom, you're right on the same page that we are starting on. Now that this is looking like an implementation or an implementable project, we're not just in Vision Quest Innovation Workgroup land anymore. So the plan is to get that list, sequence it, divide it into sort of functional subgroups, sequence it, and move forward. So as we now approach something that we hope to be real. There'll be more of a decision log, issue paper. This methodology document will track the process. Many of these decision points will be shared, and we'll be looking for feedback. But let's switch to the next slide. So this is our beginnings of a list. Now I'll say there's nothing here that has to be final, and we are looking for feedback. So conversation, input, written input afterwards, suggestions, over the shoulder, slaps, anything are good. The carriers serve sort of a two-style role. We need their help designing this because they're going to be the implementers of the network contracting, and we need their advice as a sort of vendor partner stakeholder. So we will be working with the carriers. This one's a start now. There were earlier in the project some one-on-one carrier meetings. These will be respun to be a group including all carriers, and we will be going through the key components of the program design, looking for feedback, looking for suggestions, and again, all those real world things about what we need to do when we start to implement. A second group that we've envisioned is the sort of member perspective, the Health Equity Workgroup and the PEB-OEB member advisory groups. That's not as now, but it's coming up soon, where we'll want to let some of the guiding principles and basics of the direction get socialized. The next slide, please. The boards, again, they're our sponsor, they're our end user, but they're an important stakeholder for design as well, because if we start down a path and it's not consistent with what they would want to vote for at the end, then we will have wasted time. So we're hoping after we're through renewal season, which is another month or two, that we will do a reintroduction, review, reset on the COE program and the approaches and the draft decisions and plan designs with the boards. And then we'll continue those discussions probably at board meeting, pre-scheduled board meeting times, with the goal of an October selection of the flavor of the COE that will have been developed. The IWG, that's pretty easy. That's us, and we will be discussing this topic, I think, quite a few times, maybe every agenda, Margaret, I can't quite recall, but this topic will be fast and furious on the IWG. Then the last one, Tom speaks a little to the provider side. Now, the carriers contract with the providers, and we imagine they will be doing a fair amount of communication and preparation, really. But we did envision that there would be something, a few months from now, where we get the medical association or hospital association or the subgroups you mentioned, and we just sort of let it be known and ask for input just so we know what everyone's thinking. So that's what we've got so far. We've got a little timeline, and a lot of it revolves around pre-existing meetings, and then this series of carrier sessions will be a big one.
Yeah, this is Tom again. So when I read this and I saw providers and then I saw ASCs and hospitals, I looked at it just with the people who are doing the physicians weren't outlined. Now, and the other part is that it didn't deal anything with their society structure. So the Oregon Association of Hospitals and Health Systems. I could imagine a hospital hearing this and not being happy with it, shooting a rocket or two, and the rocket would be they would get that barrage of rockets if they are somehow able to coalesce in their association. The same thing would be with the orthopedic surgeon. So by being able to be up front with the societies and associations, besides just the place, going to the places individually where this is happening, we at least can explain what's behind it all, and two, maybe even see if we can get agreement. It's very possible, in particular with the orthopedic surgeons, they may be very helpful in terms of identifying what really is meaningful when it comes to clinical quality metrics. So it would be almost asking for a partnership to say, help us make sure that we've got the right metrics.
Those are great ideas. We'll take some notes and expand this section of our plan.
Okay, great, thanks.
Okay, I think that's the end of what we had for stakeholder engagement. Just letting you know that it's a different level of priority now that we are both regrouping with a big new data set and working towards an implementable program. I think we can move to the next one. Emery, is this me also?
Yes,
think-
actually,
think
unless
it
you
is.
want me to handle it. But,
No, that's good. These are draft. There might be too many of them. This is helpful for us as the project team so that when we face all the myriad of little decisions, and there's one where A looks good and B looks good, we can go back and sort of map them against our guiding principles. So on this one, consider what you read draft. Consider there being sort of a quiet request for wordsmithing or critique or crossing off or enhancing. This came up after a couple work sessions with staff and consultants. So there's nothing final here. I'll read the goal and see how it sounds. The goal of our COE is to provide a pathway for more PEB and OEB members to have better health outcomes by using highest quality providers for common high cost conditions and procedures. Any improvements or changes to be made to that?
Hard to criticize that.
I agree.
Okay, if anybody could do it, Jeff, I know it would be you. Next slide, please. Here are guiding principles, and I should say that these have had one pass with IWG, and there have been some edits, and the first one is credit to Jeff. That is sort of a context guiding principle. The OEB and PEB boards want this to be done within the context of the triple aim, and that we're still there worrying about our population and our population's experience and the cost of the program. So I think it's hard to disagree with this one too. Maybe I'll go through a few and then we'll stop for comments.
I think there's a second page, James, right?
Yeah, there'll be more. Yep.
Okay, why don't you go through your whole list and then come back?
Okay, I'll do it. The second one, I think is also probably not too controversial. It represents the reality that we had our data reset, that we want to use the most representative data sources and the most appropriate metrics to determine quality. We want to provide quality and cost information broadly and transparently. So I think that one speaks to me. I think that we should have as few surprises as possible in this program. Maintain equity within the Center of Excellence program. reduce or eliminate any disincentives to receiving the highest quality care. We may come back to that one. You can see that there's some word parsing there, reduce or eliminate any disincentives to receiving the highest quality care. Number 6, provide financial incentives for members to receive the highest quality care. A lot of this is kind of speaking to our tiers and our travel benefit and those kinds of design features. 7, investigate additional financial incentives for members who choose high quality and low cost care options in support of adhering to the 3.4% cost growth requirement. We haven't talked much about this along the way, so it's on here as a conversation starter. Next slide, please. Strive to intervene as early in the healthcare decision-making process as possible. Again, that increases our impact and reduces any surprises. Facilitate member and provider education and outreach to maximize impact. Allow members to make informed decisions while respecting their autonomy over healthcare choices. Another one that has the real details about the rules and requirements for a member to get into the COE program. There may be lots of times where we look back to this about respecting autonomy versus the rules for playing. Number 11, achieve savings by averting unnecessary care, reducing readmissions, and avoiding complications. 12, ensure members utilizing lower quality care are aware of higher quality options. Again, we probably haven't had that discussion much yet, so it's here for a little conversation starter. 13, consider startup and ongoing administrative burdens for members, plans, providers, and others. That's a pretty boring one. 14, design pathways for non-selected facilities to improve and qualify for Tier 1 status over time. There, more than a dozen. Now I'll be quiet and see which ones people might want to go ask or comment or change.
Can we go back to the 1 through 7 first?
Yep.
The number 7 is, I don't think, very helpful. I think we get to it actually a little bit later, but that's kind of wishy-washy. What I'm I'm not sure about number 7. Can we flip I think it's number 11 that I was interested in, so we can go another slide.
Well, Tom, let me pile
Yeah.
on, because number 7 was the one I was looking at. And to me, that is essentially a guiding principle for the IWG in general, not necessarily the program.
Yeah. So let's go to 11, because I think we can be, achieve savings. And I think it is reasonable to add words around warranty and to add words around bundled payments, episodes of care / bundled payments. And I don't know how to, I think that so at number 11, I would include then something, develop pathway to warranties of care and bundled payments / episodes of care. That we might not start there, but we should end there. We should get there.
Yeah.
And then so that's what I would do. I'd be more specific than what is in number 7, and I'd buff up number 11. That would be my recommendation.
So again, I'll pile on. I think the warranty notion ought to be a separate line.
And I'm not opposed to that.
I think that makes sense.
Yeah, I want to be able to draw attention to our members, that one of the questions of our board, of an OA board member was, can you guarantee that we'll be better off inside one of these programs? Well, I'm not sure that I want a black and white situation because there's variables in this, but at the same time, we want to assure people that because we've done our homework and we've done the investigation, the probabilities of better outcome there are much more substantial. So I'm speaking in caveated terms, if there is such a word, but yeah, let's kind of try and address that as a single line.
Okay, I'd like to pop back to 7 for a minute and explain how it got here a little more.
Okay.
The one right before we say financial incentives for members to receive highest quality healthcare. That's just a reference to the tier 1 where you waive the additional cost tier or that kind of traditional plan design thinking. 7 is a little more inspired by a program that we learned some about. We don't know everything about it, but it's something they're doing in Colorado. And theirs is quality and cost. And the two things that have really struck me, one that speaks to number 7 is, let's say you had 2 high quality sites and one was half the cost of the other. They let that information get transparently to their members, and their solution or their approach to doing it is funny, I think, but direct. They give them cash. If you go to the low cost provider and save $500, I don't know, you get, Margaret, not all of it, but you get some money in your bank. And there are lots of regulatory issues and there are lots of issues around it, but because of the evolution of this COE project, we haven't been, partly because of our pay for quality approaches, partly because we have the 200% of Medicare legislation, but we haven't been building the, super low cost, high volume, low cost bundled payments in as the first step. Now, we do want bundled payments and episode payments and warranties, and all that's good. But 7 is here to open the window that if there was a way where maybe an ambulatory surgical center had the same or better quality and cost half as much, that we would investigate. That's why it says investigate instead of do it. Whether there's a way to waive a copay or do something to provide financial incentive to get the quality and save a few bucks at the same time.
So let me throw out something to react to, and that is to eliminate 6 and in 7 strike additional. And does that end up doing that?
Sure, and it makes it a little more general to go back and map our decision points against. I think that'd be fine.
What about my colleagues? What do you think?
I'm fine with that, but what I would do is put the end of the sentence after options. I would not confuse the again. This is the
Okay.
audience. The audience for this is going out into again the providers, and you throw in that 3.4, and people go, they glaze over it, don't understand it.
And
those are both
point, this is built in. I mean, that's part of our charge on everything.
Right.
So
right.
I agree with you, Tom.
Yeah, I agree with both of you. Those are both great edits that make for one better guiding principle.
Sean, did you have any input?
I appreciate the conversation. Yeah, I mean, it makes sense to me where we landed there.
Okay. Now we're back to a baker's dozen, so, okay.
Yeah, and I kind of did want to say out loud the other thing from Colorado that inspired at least me. And I think it shows up on the next slide. Strive to intervene as early in the healthcare decision making as possible. It's a good general thing, but the Colorado program I thought was novel and smart in that they have sort of an app-based thing, and the members and the primary care docs get to use it to see like the impact of the referral, where that next referral, where the care is going to be favorably viewed by the Center of Excellence style program. So that was the second thing from Colorado that I thought if we had some focused study of the decision-making pathways with our 3 different carriers and the pre-authorization process and all the things we have in place to sort of try and do a process design study to see where and how we can intervene early. Not saying that we have to have an app or we have to give it to the primary care docs, but to try and avoid the situation where your primary care doc refers you to his college friend who's across the street, and then you get there and you find out, and then you had your initial visit and you're down the road, and then you find out that he's not in the preferred cost tier or the facility or the provider, you know, like you're not in the right pathway. So those are the 2 things from Colorado that, you know, are a little bit new guiding principles given the history of this project. I just wanted to say it out loud, see if that resonates.
And James, I would note that I think number 12 on this list also relates to that in terms of ensuring members utilizing lower quality care are aware of higher quality options. And I think, you know, when you look at the Colorado example, we've been investigating. It's both in terms of making sure members are aware of the quality and cost is the approach they're taking. But I think that but 12 sort of relates to what you were just describing as well.
Yep.
And on number 8, I think that one speaks to me a little bit more in the aspect of trying to reach the member before they get to before they decide to get to surgery. And I think those were some of the savings that aren't really spoken about as much. I mean, we were considering COEs where the surgery is going to be performed, but you know, in many cases, a person may not be the right person for surgery, whether it's just too early or maybe their health condition doesn't really allow for good outcomes. And in those cases, we don't want to potentially put the patient, the member, in jeopardy of having a surgery, having to have a revision, and basically not having improvement of function. In this case, you know, if they're having surgery and didn't make necessarily the right decision, you know, because they've already gone, you know, I want to have the surgery rather than, hey, maybe you need to reconsider. So I think, at least for me, number 8, I think is pretty important to not just to think of it more, I guess, holistically beyond just the actual surgery aspect of it. But
Yeah. The other thing, and I agree with you 100%, Emery. I think that it is very important. We need to think of this also as then the same principles that we would use when we expand beyond just, you know, knees and hips. You know, when we think of other interventional activities. And I think they're consistent. They're good. I'm happy with all of them.
I wonder if I could add a thought that I think is kind of interspersed throughout some of these points, but just following the example there that we just had, you know, there's someone who is not medically appropriate for this surgery. Now, at that point, I guess my overall comment is really about concierge or like someone is helping this person through. If their experience of all of this is just no, you can't get your needs met. So there, and like that's not super helpful, right? And that doesn't like obviously they're in pain or they're having a problem if they're even thinking about surgery, right? So um just saying no isn't enough. That they are then channeled into something else. Like if the reason why it's a no is because they're smoking, then they get directed to a tobacco cessation program. Be like, let's work on that before we start doing knee surgery, because there's increased chances of infection if you're a smoker. Or if it's obesity, then it's like, let's work on that, which by the way will probably help some of the joints as well. And um that they're being reconnected with other resources, right? And so just trying to like, where is that essentially? It was like, what is the lowest intervention with the most effect that this person's being channeled towards?
I think it's in 8 somewhere.
Yes, I think you're right. It's got to be something about that. But it's not purely about surgery decision support,
Right.
Yeah.
Right. 8 and 9 have both got.
Yeah.
Some,
We get into the specifics for knee and hip with some of the recommendations. I'm never been a good wordsmither, so if we can make sure that we capture what Sean just said, it'd be very helpful.
Okay, we'll do that. I think somewhere between 8 and 9, we could maybe add some levels of support or some other good concepts to not have it be a no.
Yeah. Coming
So
up with defining alternatives is
And like, whose responsibility is that, right? Because it's probable that the facility itself, the surgery center, is not going to see that as their problem. They're just like, either they're going to accept them or they don't. And so you kind of have to make it clear who we're expecting to do that kind of
yeah.
So I agree with what you're saying, Sean. I'm stuck a little bit on whether we're straddling an application or a principle. And so I guess the wordsmithing will land it in the right place.
It's probably both, in my opinion. I
Yeah.
think we can definitely wordsmith it to talk about the different healthcare pathways. It's not just surgery. It's like PT. And well, I mean, specifically in this case, I guess it is PT, depending on the COE we're talking about. But, there's definitely ways we can wordsmith it to talk about maybe redirecting care to the appropriate setting, and it's not whether that's inpatient, outpatient, physical therapy, or whatever else, obesity programs in this case. But we can definitely add and modify. And if you have any, I don't know, suggestions, then we can definitely work around that.
Good, Emery.
Even number 10, where we're trying to respect autonomy over healthcare choices, like this is all that healthy tension or scary tension between not getting it and getting it, or getting something instead of it, feeling empowered, not dominated. I think these 8, 9, and 10, we'll take this conversation, see if we can tune that up a tiny bit.
Thank you.
Okay, yeah. James, do you want to go down the rabbit hole, or is that not worth the discussion that we had?
Which rabbit hole?
The one we had internally on the call. It's kind of like I think
we're already there. I think you already started down.
Let's. I don't know if it needs to be more explicit, but I think we are kind of like asking for the plans. We're also asking, the members, the IWG, for their value mission statement. And so one of the questions, I think it might have been brought up on a prior call, is, so if you do have a patient who does not qualify medically based on whatever conditions, I guess, is the IWG willing to take a stand where, if a facility, a COE facility, tier 1, isn't going to accept them because they don't qualify medically, how does the IWG feel about them getting surgery for a tier 2 facility or below, or whether the IWG and the COE basically says, no, you shouldn't have that surgery? Because that's kind of like, I don't know if that's the healthy tension or if that's the nervous tension, but there are situations where there might be there might be a stance to say, hey, no, you really shouldn't have the surgery, in contrary to where the member might be feeling in this case.
This is one of um, obviously let's say the member has it in his or her head that the surgery is the right thing to do, and yet from a standpoint of whatever their complications or whatever, they are not they don't meet criteria. So it's, what do you do when providers don't follow accepted criteria? For this all to work, each of the if you're having centers of excellence, you need to have criteria around which you go ahead and do stuff versus not, and you have to have some pathways of um, of evaluation. And we've talked about, for this particular situation, conservative care, PT, all of that. We've talked about are there, particularly for knees, or is there a BMI over which one says no until you get that under control? So a whole series of specific criteria that have to be met. And the health plans deal, this would fall onto onto the health plan and their relationship with the facilities and their contracted surgeons, of saying, hey, you've got to meet these medical criteria. I mean, that's built into the concept of I think of centers of excellence, is that you have medical criteria and you follow it. There, as Sean just said, you have to have off ramps for people who don't qualify, so that they don't only get the 2-letter word no. That there's they know how they can proceed. But it's not a rabbit hole. It is a absolute critical component to what we're putting together. And if we don't have it, we've we've really caused, we've run into all sorts. A quick sidelight, fascinating for me is how people and I've had personal experiences in my practice where people don't qualify for various types of procedures. They then go to Venezuela or Costa Rica or Mexico and come back with all their complications, and then we have to take care of the complications. But the same thing could happen with this, and that's just life. But this is yeah.
Years ago, not that many, I tore my ACL, and it had been mostly torn, and I tore it the rest of the way.
Yeah.
And my PCP referred me to a nice conservative surgeon. He said, "You're too old. We
Yeah.
can't do surgery on you. You don't need a new ACL. Just exercise."
Yeah.
What do you think I did?
Oh, you went somewhere and got it repaired.
Yeah, I sure did.
Yeah.
So I used a guiding principle.
Yeah, autonomy.
10.
And
Autonomy.
and I don't know if your insurance ever stepped forward and paid for it, or that, none of my business. But that's just the complications of insurance. But we need to have criteria. We need our health plans working with the facilities, working with our contracted physicians to make sure that they're following that, and then reporting on outcomes and following clinical metrics. I mean, that's this isn't simple stuff, but if you don't have that set up ahead of time, you're you can't say no.
Well, let me ask you the question, Tom. I mean, to some degree, we get the program in place and there is a natural progression of perfecting the program when we've got more data.
Yes.
And there are implications not just on musculoskeletal procedures, but also in other areas of care that's covered under the plan. So I'm just kind of wondering whether that's a later phase, what we're talking about.
You mean later to have to deal with the issues of criteria and the like?
Well, tightening the criteria for rejection or disallowing.
I think it needs to be fundamental. I think it is fundamental. When you look at our bariatrics program, we didn't authorize bariatric surgery for people with BMIs of 33.
So here's one of my concerns, Tom, and that is we look at not bariatric, BMI as a metric.
Yeah.
And I believe, and I could be wrong, that BMI is going to vary by different ethnicities and
the good
cultures.
news. Yeah, the good news is with BMI, it is pretty darn. When you're at 40 or higher, the wiggle room is gone. Muscle mass issues are less, and that's something that we can explore with our clinical experts.
Okay.
As an example, in other words, there may be situations where you're able to get outside of that. With muscle mass analysis, or a lot of different things.
Well, these are just areas where not having a medical degree makes me nervous about certain recommendations.
Yeah. Well, I have a degree, but also I'm also nervous. So all of that needs to be validated. That's one of the reasons. That's one of the reasons that I'm interested in getting on board. The organized. That's why I ask the Orthopedic Society to say, work with us on this. Make sure we've got it right.
Yeah. Good. Thank you.
Okay, we don't have any more slides. That was a fun and interesting conversation. Is there more before we switch to the next topic?
I guess I need to ask the question, do we need a break or we just keep going?
I'd like to keep going.
Okay. All right. But I guess just to finalize that value statement, we do have, I guess we'll wordsmith it, make some revisions. We can discuss offline about those revisions, and then hopefully present, I guess, the final for approval in April, and take those as part of the stakeholder discussions, as you mentioned, Tom. Take them to the plans, take them to the physicians, facilities, and just make sure everyone's on board, hopefully, and get their feedback as well. But thank you for that discussion. So section 3, the COE project plan and program design updates. So let's move on to the next slide. So what we did was to take a subset of the project plan we presented earlier as well, and just put some of the status of where we are on some of this. And these sections, we're actually going to go in a little bit more detail later on some of these sections. So in terms of the data, obtaining the APAC data, I get, in terms of data request, we made some minute revisions to it, but I think it's generally complete. In terms of finalizing the request, we did talk to APAC, and hopefully we will receive the APAC data, but we are working through, I guess, some of the legal aspects of it as well. Margaret, is there anything you want to add on the APAC data?
No, I think that summarizes it. I mean, we are in the process. We've articulated the specifics that we want in terms of the actual data extract. And yeah, per APEC statutes, there are various, administrative and compliance paperwork and aspects that we need to complete. So those are in process.
Okay, thanks. So in terms of analyzing the metrics, in terms of identifying that data partner and sending that APAC data to the partner, we have been in discussions with a third party to essentially run the APAC data. I think we are moving forward. We're just having discussions, trying to get through legal and other issues there. So once that is all done, then hopefully we will be sending the APAC data to the partner, and they'll be running the metrics, which will then be part of section 1.2. So the metrics and scoring, and determining initial metrics and scoring methodology. This is, I guess, still underway, where we do have a certain list of metrics, but it's not final. We are working on that, and we'll go into a little bit more detail in one of the slides. But we'll talk about some of the metrics, and then potentially get feedback from the plans as to the list of metrics, as well as the IWG and others. And then once we get that set, then we will determine scoring methodology and the percentages for each of those metrics, as part of that discussion. So that is currently in process. Section 1.3, facility contracting requirements. So Cindy and Prachi will go into detail on this in terms of the requirements, including the warranties, member assistance, and performance guarantees. We did develop an initial list, and we'll show it to you. Let's move on to the next slide. While we develop the initial list, we'll have these conversations. We'll get your feedback on that list. We'll talk to the plans, and they'll get revised, and we'll present additional versions of that list as this process goes on over the next few months. 1.4 plan design. So we do have the final plan design that we provided last year, as shown on one of the slides, and there's two other potential options that we'll talk about in today's presentation with that as well. So trying to give you some options as to where you want to go with the plan design for this COE. And then travel benefit. This is the one where we actually don't really have a follow-up on it. We are still in process. We're talking about it and just trying to determine whether there needs to be a stronger travel benefit involved, especially in tandem with the plan design in this case. But moving on. Next slide, please. Thank you. So the data update. So this is a little bit more detail on it. So as mentioned, we had the discussions with APAC about the data request. We did expand it, and we are working through the legal requirements. And then on the right, I think we did talk about this, need to agree on data use requirements and discussing metrics. So the metrics are on the next slide. So let's move to that. Metrics update. So this is the list of metrics that we are planning on getting from the third party. At least the list available metrics are there in the top section. So that includes metric called unanticipated encounters. So what's included in all that is surgical site infections, readmissions, and emergency room visits after the surgery. Another metric would be mortality, complications, is another metric. Then there's another metric that's called patient safety. And this is based on ARHQ patient safety indicators, or the PSIs. And the final metric would be length of stay. Most of those metrics are risk adjusted, but length of stay is not risk adjusted, but it is essentially regressed based on typical and expected in this case. We are also talking about potential additional metrics that might be measured and used. Some of those are kind of like based on some of the prior information that we showed, as well as maybe some potential requirements for the contracting. But that's the current list that we have available. Prachi, was there anything you wanted to add?
No, I think you covered it well, Emery. I think the other metrics we were thinking about is, just as we talked about earlier, is providing that pathway for those facilities that are currently not in tier one. So helping them understand, where do they stand with what metric, so that, again, there is opportunity for them to improve in those areas and potentially qualify at tier one. So as much of information as we can share, it will just help, make the program more robust and better.
Yeah, thank you. Yeah, so with that, I guess I'd want to open it up if there's any comments from the IWG regarding some of these metrics or the data. Okay.
I think they're reasonable. It would be nice to have a patient outcome measure at some point. In other words, did their life get better? Did some functional status or something like that? I just don't know what that would look like. And again, I would ask clinical experts to see if they knew what that may be.
Yeah, and I think that would be definitely an important one. I'm not sure if it's necessarily it may be a nice something
It for
that
sure
is
is an
required.
APAC. Yeah, it's for
Yeah.
sure not APAC, and it's just when you think about AAA,
Yeah.
it's cost, quality, and service, so it's just an element.
Yeah, and it might be a requirement to stay, tier one facility. And I think what the next slide talks about the contracting requirements, I believe. Can we move to the next slide? Yeah. So yeah, in terms of requiring, what would be asked of the tier one facilities and of those who want to stay in the COE, I think, that might be a really good metric, like a patient survey information to get. But with that, I guess I'll turn it over to Cindy and Prachi to kind of go over what we came up with as our draft clinical requirements in this case.
Thanks, Emery. So initially, phase one, we're looking at elective hip and knee joint surgery. So this kind of outlines the codes that would be included in that for both outpatient hospital ambulatory surgery and inpatient hospital. One thing that I do want to make sure we call out is that the COE program will be built around elective procedures for adults. So if someone were to develop cancer, bone cancer, something like that, that isn't going to go through this COE process. These are really for elective surgeries, probably mostly related to osteoarthritis and other issues such as that. So this first page kind of outlines these clinical clinical contracting requirements. Again, this is draft. We're looking for feedback. We'll be working with the carriers and hopefully eventually get some feedback from some of the other stakeholders on some of these. But we want the facilities to take responsibility that making sure patients have undergone conservative therapy before they come in for an elective procedure. So that might include medications or physical therapy or activity modifications. So definitely looking for them to confirm that. Would like the facilities to also confirm that the patient meets medical policy criteria as defined by the carrier. So there wouldn't be a requirement for these tier one facilities to go through the prior authorization process. We expect them to take responsibility to make sure that members are medically appropriate for the surgery. The patient would also be evaluated for appropriateness, and the provider would take steps to optimize patient status prior to surgery. And this is kind of what we were talking about a little bit earlier. These criteria are actually from a study preoperative risk factor screening protocols in total joint arthroplasty. And that's actually been recognized by the American Academy of Orthopedic Surgeons. The exact criteria are, still kind of being developed, but these are sort of the initial criteria that appear to result in better outcomes, fewer infections and complications related if folks kind of fall into these categories. So looking at BMI, less than 40, non-smoker, well-controlled diabetes, so we don't want any uncontrolled diabetics to be undergoing surgery, a hemoglobin greater than 11. Nutritional status is actually what's reflected by the albumin level, so making sure that folks are nutritionally in a good place, and then evaluating methicillin-resistant Staph aureus status to make sure that precautions are taken if that was positive. We would want to kind of outline sort of what are the requirements or those pathways for folks who don't meet these specific criteria. So what is our expectation of what the facility and the surgeon are going to do? We would like for them to collaborate with the primary care physician or other specialists to make sure that members meet these criteria as they go on their pathway to the surgery. Also compliance with best practices in post-surgical pain management, and we'd like to do some work with the carriers and the providers around exactly what is included in that. Patients would be prescribed post-operative physical therapy and have post-surgical follow-up by the facility and the provider. So any thoughts or questions on the kind of draft clinical requirements? Okay. If you want to go to the next slide. And so these are administrative contractual requirements, so less focused on the clinical piece and more focused on just how this will operate. All members, again, would be evaluated for appropriateness, and the facility provider would promote conservative therapy prior to surgery. We'd like to have expedited scheduling for folks who go through this program. So work with, again, the carriers and the providers to understand appointment availability. So if someone does want to go through the COE program, making sure that they get in a timely way once they've been identified, and also that their surgery would be scheduled timely. I know right now there's a lot of delays for providers and facilities being able to schedule things. So we want to try to work with them to figure out what's appropriate and reasonable for members. We'd also ask that the Tier 1 facilities offer a 1-year warranty around each procedure that would include any revisions that would need to be done resulting from the surgery. Looking for quarterly and annual monitoring reporting of these metrics for both PEB-OM specific and then for also their full patient panel. We will be looking at kind of all of the patients that they take care of as we look at the tiers and the outcomes criteria that we want our Tier 1 facilities to meet. So definitely want to have some reporting around that. An annual review, they would agree to an annual review of performance, including outcomes, patient satisfaction, and chart reviews. And the chart reviews would be used to assess for their compliance with medical necessity through the plans, that they are evaluating members for appropriateness, assisting them to address modifiable risk factors where they're identified, improvement of function assessments, and then complications. And then depending on where we land with our outcome thresholds for Tier 1, we would expect that established center of excellence Tier 1 providers would continue to meet volume and outcome thresholds based on that annual third-party data analysis. We would want them to do a PEB-OEB patient-specific satisfaction survey sent post-procedure, identify, what's the appropriate timing for that. And Tom, this might be an area where we could get to some of that AAA around service and members' perception of whether their function has improved as a result of the surgery.
Yeah.
And then collaboration with carrier advocacy teams. So we want the facilities and surgeons to collaborate with the carrier advocacy team to assist with member navigation, support for records transfer, scheduling of appointments, travel and lodging, return to home, discharge planning, all those things. So we would expect that collaboration to occur. And then ultimately, potentially in year 2, we'd like to see move to a bundled payment arrangement where that would include the preoperative evaluation, operative stay, and then the postoperative piece as well. And they would all be included in the bundle. So any thoughts or questions on this?
I think it's very complete. I like it a lot.
Thank you. Okay.
Yeah, and so, I think, part of the stakeholdering, we're going to be talking with the plans and facilities and about these requirements. And, I think this is really the first step where, we're presenting it to them. And we'll be holding follow-up meetings to, discuss and to, I guess, refine potentially. And, but, if anyone at IWG or others, additional comments, questions, feel free, and we will, take your feedback and discuss as we move forward in this process. Sorry.
Okay, I think that's it for me, Emery.
Okay, next slide. Let's just go back one. Thanks. So other considerations, minimum threshold outcomes. I think this is tied into our, trying to find pathways for our tier 1 facilities in terms of the quality outcomes, right? The outcomes that are reported based on the information in the prior slide, making sure that they have remained higher quality, and just basically saying we don't want our facilities to fall below certain levels, whether it's average or 75 percentile, or it's those kinds of statements. As we move, develop and make this COE stronger, we'll want to ensure that the facilities that are participating are high quality and demonstrate that they're high quality. So minimum thresholds, where they're set at, but we want to keep some minimum thresholds in order to be considered a tier 1 facility. The next couple slides just provides a little bit of information about the different procedure codes and diagnosis. So next slide, please. So just joint surgery codes here in regards to what might be considered. Next slide. One more slide, please. Chris, can we move? Thanks. So plan design options. So this is the plan design that we had proposed towards the end of 22. So the current benefits, you can see there on the left, additional cost. That's okay. Actually, can we go move back?
Margaret, you might have to take over. I see my slides. I have no idea where I am.
Okay, let me, you know what, Rose, give me just a second. I can go ahead and pull it up.
Okay. Wait, here we go, maybe.
Is it back?
What
Okay.
slide number? Emery?
Let's move back a couple.
Do you know what number?
It would be slide, I'm getting to it on the other one. So let's try slide number 56 in the PDF.
56. Oh,
Yeah, the one
Oh.
prior to this. Thank you.
okay. Wait,
So
this one?
no, the one below it. Yes, this one. Thank you. So
There's a delay in the slides. So when you say this one,
Yeah, it's a number 21 on the slide
21.
itself.
Okay,
Yeah,
that's what I need.
so,
Okay.
Yeah,
Thank you,
I
Margaret.
know the PDF number versus slide number. So we're on 21 in the bottom
Okay,
corner.
thanks.
all right, thank
Yeah.
you. Yeah, so the current benefit right now, there's additional cost here for knee, spine, and hip surgery, and in addition to whatever plan, deductible or copay co-insurance is that the member is in. So what we had proposed was to create a tier 1, where that additional $500 cost tier copay would go away, and then also travel benefit would help reduce the disincentive. So those who might have to travel to a tier 1 facility would get a travel benefit to help with that. Our tier 2 would essentially be no change. So the facilities that are, mill quality would be falling into tier 2, or the high quality facilities that don't want to comply with the contracting requirements to be a tier 1 would then fall into tier 2 in this case. So there's no change for that. And then for tier 3, those facilities that are kind of low quality and don't really want to help improve the members' care pathway, we would basically make a disincentive for the member. So a higher additional cost here in this case, whether it's $1,000 or even more, to basically say, hey, this is not a facility that we would recommend you go to. And so there would be a disincentive. Those who don't have a tier 1 but might have a tier 2, you might get in your region might get a travel benefit in that case. But yeah, we would be trying to disincentivize those in tier 3. So this was our proposed plan design at the time. We had some discussions around it, as well as kind of showing I guess some facilities and regions based on the prior scoring methodology. So this was the proposed. I guess there was some discussion around it, but I don't know if there's anyone from the IWG who wants to make any comments or thoughts whether this is still kind of like a potential or reasonable plan design to move forward. I would open up to the floor. Okay. So this was the proposed. I think we had talked about potentially having a couple of other plan options. So let's move ahead one more slide. So, some of the concerns that were brought up, whether the disincentive is too big or rural travel issues for those members, whether traveling, going to a metro or Willamette region might be a little too onerous for some of these members because they just don't have a facility that qualifies. So some potential options were to eliminate tier 3. So essentially you would have tier 1, tier 2. So you do have a high quality provider. In lower cost sharing, you go tier 1. And then tier 2, we might consider increasing the additional cost to your copay. To make it, if you want, there's facilities that are tier 1, they're high quality, and they're going to give you all these great benefits. You should go there. Otherwise, pay a little bit more to stay with your tier 2. So that's one possibility. The other possibility is to start out, basically eliminating tier 3, but phasing it in as we keep getting data to see where it gets more and more accepted or socialized, and then, essentially creating that disincentive for low quality providers, the facilities that aren't performing very well. So those are a couple of potential options to, I guess, to not make straight 3-tier program to start out. But there's also another potential here where, kind of along the Colorado line. So if, in terms of contracting, recontracting, provider willingness to participate, we will be getting this data. We will be looking at the facilities and whether they're high quality, but maybe we start doing an information only approach where we get in front of the member quicker, prior to getting that surgery, to, aligning with one of those values, I can't remember exact value, like values number 8 or something like that, where you get in front before they decide on the surgery to get them, or where they're going to have the surgery, to get them the information, the quality information, and the cost information, to get your surgery done in a better place, to maybe get into a place where you do have the contracting requirements and you tell them, hey, it's like, this is the place to go. And so that's one possibility. There are different app, I think, with Colorado, they use an app as well, to get in front of the member. And what we would do there would be focusing on the decision pathway, do early intervention. And we would need to, talk with the PCPs or the physical therapists as well, prior to them setting a schedule with the, appointment with the orthopedic surgeon and having that surgery scheduled. So that's one possible approach that's a little bit softer. And then like phase in of contracts, some of these elements we believe are very valuable and can definitely help the, achieve the triple aim, and then just phase in these potential contract requirements over time, if we're not going to go straight to a tiered system. But that's another possibility. And then we would, also look at cost efficiency, and the impact on cost on, members and the plans, to maybe talk about some various plan design options to make it, to potentially incent members to go to the higher quality facilities in this case. So those are some softer plan design options that could be considered. But, I guess, as we talk through the values and how much the IWG wants to, focus on the higher quality providers and incenting members to get there, that would help inform what kind of plan design pathway we would go forward. But Jeff, do you have a comment?
Did I raise my hand? Well, I do.
No, you came off mute, so I figured you were going to talk.
Well, I tend to think that if we start with a tier 3, it actually helps negotiate tier 1.
Okay, gotcha.
So not having it softens the desire to be in the network.
Gotcha. Okay.
The catch that we have is with all the tiers is there is this kind of gradual, you look at the 40 or however many facilities we had, and it's this kind of, slow curve, and trying to figure out, what makes someone tier 3 versus tier 2 versus tier 1 is a bit of it sure be nice to have nice clean demarcation lines, but we don't have much of it. So that's my only concern of tier 3 is that, it's kind of an arbitrary decision to say, you're okay, but you're bad, because tier 3 kind of feels bad, as compared to, that's just the catch.
Well, Tom, I might be inclined to describe or to say that generally I like the notion of a 3-tier system. And I think the initial structure, from a benefit design standpoint, makes sense. Mm-hmm. I think our hope is in getting the greater amount of data that the line of demarcation between tier 2 and tier 3 grows with the inclusion of more data.
Yeah.
If that is not the case, then I think we're going to have to rethink the tier 3 question.
Yeah, I agree with that entirely. The other part is the, when you've, Emery, when you put in this phase in component, I think we need to have the system up and running for a quote a while, let it be a year or so. But the issue around bundled payment is one that, after that lead-in time to stay in tier 1, you have to do that, and you have to participate in warranties. So that would be the other component that I would like to see. I wouldn't start with it, but I would make sure that everyone knows that's the direction we're going. Let it be in year 2 or year 3.
Yeah, our original
and
plan was to have those contractual requirements. If you were on B tier 1, you would have to have those contractual requirements.
Yeah.
And so the bundle payments would be naturally part of it in tier 2, or in year 2, not tier
Okay,
2.
great.
But to your point about performance, I think some of those reporting requirements that Cindy and went over on the other slide, the outcomes, and some of those, the member outcomes, as well as readmission and other things, getting that information, to your point, Jeff, taking a look at it and seeing what's truly the performance of these plans, not just through APAC, but for OEP and PEB members and all of the members that are being treated by the facilities, getting that information and using that to help stratify the facilities, I think would be greatly helpful, I think, right, in terms of saying, hey, these are the minimum requirements, you haven't met them, or you didn't meet them, and therefore you can potentially move up a tier or not, in that kind of situation. At least that's
So
my thought.
I think our support of your initial plan design helps you model without having multiple, trying to calculate all over. So you can give us some financial impact on looking at it a couple ways, not a half a dozen or a dozen.
Yeah. Okay. All right. Yeah. So we can definitely move forward, keeping in that tier 3, 3-tier plan design, and also the contractual requirements for tier 1. And so we can definitely move forward with that. We'll have the stakeholder discussions, but we'll follow the IWG's direction on that. And that's actually the last slide of the presentation. So I guess thank you for your discussions. I didn't know if there's anything else that someone wanted to have for final thoughts or questions before turn it back over.
Let me jump in, because I think we are going to want some financial modeling coming up. And Emery, I would ask that when you do that you tell us which elements are saving what. So, for example, negotiated fees is one element. Your estimate on lack or reduced complications would be another element, because that's part of the justification of the program. So to the extent that you can give us, you can categorize the savings in 2 or 3 areas, that would be helpful.
Okay. Yeah, we can definitely work on that.
Anybody else?
Nope.
Coming
I think
together. I appreciate the work.
Yeah, I think we're moving forward.
Okay.
Yay.
Yeah, and as mentioned earlier, I think there's a lot of plans listening. We will be setting up those calls to have discussions. So I'm sure you have lots of comments, and we'll look forward to those conversations going forward. Thank you.
Yeah,
And just the last thing I'd say is, I don't know if I would be super excited about a slow, like, multi-year. I mean, some part of me just thinks about just like doing it, and like, here's the gate and then we're going. But you guys are closer to the negotiation process, so I'm open to suggestions, but that's just my inclination.
Yeah.
And my only request is that we have a list, an actual list of who we call stakeholders. To have that be explicit. So if it's ASCs, it's what ASCs. if it's surgery groups, be explicit about that, so that we can, because I think the key here is this is not a one-off, and so we have to have the principles right, and we have to execute this one right, because it's going to lead us into things that will do in future with future medical interventions.
Okay, I lied. I had another thing. So we talked about this, and so I'm simply restating something. So this is not a new thing, just to be sure it's on there. I would like, when we're finalizing and expectations and the model and the tiers and the metrics, to be sure that we're remembering the discussion we had about patients not just like running into a door that's just like in their face and no. And that's, in other words, I don't want our members to be treated as a hot potato if they don't meet the criteria. Then everyone's trying to get rid of them because they don't want to be seen as like the ones that are responsible for them. Instead, that the contracts and the agreements have a clear line of responsibility of where these people go if they are not medically appropriate for surgery.
Yeah.
You know what I mean? So like something happens to them, and it's not a question about who's responsible for getting them to some sort of help, some sort of getting their needs met in some way.
Yeah. They don't fall off a cliff. They actually do have their pathways to move forward in terms of taking care of their problem. Yeah,
that's right.
I agree, 100%.
Actually, there is one more thing, and that is, I don't know how important this is on the PEP side, but it is on the OEB, and that is the northeastern border, identifying to see whether there's any facilities in the Tri-Cities area of Washington and across the eastern border. So I don't know whether we need the carriers to nominate somebody or whether I mean, they're not going to be in the APAC database, so we're going to have to go to another source to consider that. But that's a concern that's coming out of the OEB board, that people living in that area might have an option.
Okay. Well, we'll definitely focus on the border facilities. I think the APAC, Margaret, correct me if I'm wrong, the APAC data will have any Oregon member who went to those locations. And I mean, we do have other data sources that we can try to use to supplement that. And, you know, with a third-party vendor as well, I mean, we can have that discussion to see what kind of data that they have on those regions.
Thank you.
Yep.
Well,
Prachi, was there something you wanted to say?
No, I appreciate the discussion. Good.
Well, thank you.
So Margaret, that takes us to public comment.
Yes, it does. And to my knowledge, we do not have any public comment. Just confirming that. Rose, can you confirm?
Yeah, no public comment.
Great, thank you.
Well, I guess we are at our time of adjournment. I want to thank you all that presented. Really good information. I think we had a productive meeting. So I will call this meeting adjourned.
Thank you all.